So let's start. First of all, thank you all for coming, and I'm still waiting for the rest of the guys to come and our colleagues. Welcome to everyone, and thank you for joining our webinar on digital psychiatry, ethical consideration in AI-driven care. Before we officially start this webinar, I would like to remind you some ground rules to ensure the flow runs smoothly. We have to do our best for this so that we can get the most of it and try for these colleagues that are going to be with us to be more interactive in the process. Please make sure your microphones are muted when you're not speaking. You can share your comments and questions on the chat. Dr. Joan will make sure to summarize the questions and ask them to the presenters and panelists on your behalf. We will also have time for interactive discussion and live questions, as I say, after the presentations and during the panel discussions. An evaluation link will be shared on the chat by Dr. Fatma Svilem at the end of the webinar. Please fill the form. Your feedback is essential for future events. We will also send you an email with the evaluation if you have to leave earlier. I would like to have, first of all, Dr. Davor Music, WPA Digital Mental Health Section Chair, and Dr. Lamia Zouimi, Early Career Psychiatry Section Chair, deliver the welcoming address and move on. Ms. Lamia?
Yeah, thank you, Nico. Thank you very much. So good morning, afternoon, and evening, everyone, and thank you for joining the Digital Psychiatry webinar. This session is a product of a dynamic collaboration between our section, the Early Career Psychiatrists, which I'm honored to chair, and the Digital Mental Health section with Dr. Davor Music. And I think what makes this webinar very special to our section is that this is designed by early career psychiatrists for early career psychiatrists, which provides a space for emerging voices to lead the conversation on artificial intelligence and how it is reshaping mental health care. So today we are not only talking about artificial intelligence and its innovation, but we are also talking about the ethical questions it raises, such as privacy, trust, equity. We are also very much looking forward to further collaborations across sections, and that's why we warmly invite participants to join both sections. We will publish the different links to join both sections in our chat, and we will also remind you about that at the end of the session. Saying all this, I would like for this space to be a sparkling opportunity for actions and insight. Thank you, everyone, again, and let's dive in.
Thank you, Lamia. Let's go to Dr. Davor Music, one of the key innovators in digital health.
Hi, everyone. It's so amazing, you see, after over 25 years of being within digital mental health, when I, in the beginning, was totally alone, to see so many people today interested. Better late than never. I would like to say thank you to all of you who has been working on organization and preparation of this here webinar, and crossing fingers that we will continue our fruitful collaboration. So let's start.
Thank you, Davor. As I told before to the presenters, I say again, we already stabilized 10 minutes for everybody. Please try to make it 8, and at around 7.5, I'm going to give you a heads up. Let's start with Dr. Mariana Pinto da Costa from King's College London, UK. Dr. Mariana Pinto is a lecturer at the Institute of Psychiatry and Psychology in King's College London, and a consultant psychiatrist at South London and Maudsley NHS Foundation Trust. She's an invited professor at the Institute of Biomedical Scientists, Abel Salazar at the University of Porto, and the floor is hers.
Thank you very much for the kind introduction and for the invitation to contribute today. So I'll be giving an overview of the ethical considerations about digital psychiatry, and I will be asking some provocative questions along the way that maybe we can discuss in the end, or they might be food for thought. So digital psychiatry has the potential to revolutionize mental health care.
Mute. Anybody that doesn't speak, please mute your microphones.
And Thank you. And this focus ranges from the prediction of future illnesses, early detection of illnesses, assessment of illness level, and improving access to treatment. So I'll give an overview of how technology has been used, as well as its potential future pathways and ethical questions that arise. So an important use of technology are the electronic health records, and this will possibly lead us to have real-time patient health data, which the care teams have access to, with dashboards that link, for example, primary, secondary, and social care data to produce an integrated care for patients. However, when we're now moving towards these complex data collection systems in a health information ecosystem, this poses questions about the different users that can have access to the data and would be able to modify it. So, for example, would the electronic health records be retrieved by all health, social, and justice authorities, as well as patients? What about if there are disagreements about the content of the joint history data? What would be the mechanisms that would or would not allow for modifications? Or even a more provocative question, will all this data in the future be publicly available anyway, disappearing what we have the current notion of privacy and confidentiality in healthcare? So these are some provocative questions for us to reflect and discuss. Another valuable use of technology is the prescription without paper, where the medication prescribed can be collected in the pharmacy directly. And you can see in this slide, this cross-border e-prescription is working already in several EU countries. So patients are able to go to a doctor in other country, and their healthcare data from their home country can be consulted by the doctor overseas. And you can see here in the slide a list of countries where this is working already at the moment. So patients are able to get the information cross borders. However, when this was set in place, and even actually several years before this was operationalized, there was a lot of discussion because EU member states have different data protection and confidentiality laws, which many had perceived as barriers to such initiatives. But I think that this initiative shows that when there is political will, you can put such projects, including like international projects, in real life. So this is an example. Now, moving to another device, which are sensors. So sensors are devices whose purpose is to detect events. And here in the States, the Food and Drug Administration has approved the first sensor pill, which is called Abilify MySight, the antipsychotic aripiprazole. And essentially, the oral tablet is embedded with an ingestible sensor that allows patients, and if given access, doctors and caregivers to track the medication ingested on a smartphone or computer. So the system sends a message from the pill sensor to a wearable patch on the patient, which then transmits to the device. But I guess even if this was approved for a system for patients to have access to their own information, I guess this also raises ethical questions. What if someone else has access to this? And this is also an example that what we discuss about adherence to medication now is totally changed and has the potential to change significantly, because actually we now have devices that can really allow us to know whether patients did take or didn't take the medication. Moving on to another resource, which are smartphone apps. There has been an increasing number of smartphone apps for different purposes, and mental health is no exception. In the UK, we have the NHS Apps Library, which aims to help patients and the public to find health and well-being apps that meet the standards of NHS Digital. However, a few years ago, there was an article published in Nature Digital Medicine on the evaluation of mental health apps, and they actually ask whether we're using science to sell apps. And I also think from an ethical point of view, this is a question that we should ask, especially depending on how apps are developed and the mechanisms they have in terms of us knowing the information that they use. So I think these are important questions to consider. Robots have also an increasing role in mental health, mostly to help treat children with autism or older adults with dementia. And robots can vary in appearance from very mechanical looking to very anthropomorphic, as you can see in this slide. But there have been criticisms in the different ways. So, for example, humanoid robots have been criticized for giving inaccurate expectations about a robot's capabilities, with some arguing to be unethical to use when treating vulnerable populations. And in the picture in the left, you can see the EU-funded Mario project, which was developed to be a companion to reduce loneliness and isolation in people with dementia. But on the other hand, many people have a latent fear of non-humanoid robots, perhaps due to science fiction movies in the 60s, like the Daleks in Doctor Who. And well, for pets, the pet robot Paro, which is a seal that you can see here, has been used in care homes as a substitute for physical animal therapy to reduce loneliness. And interestingly, some pilot research even found a decrease in blood pressure when participants had this Paro robot, and then an increase in blood pressure when the robot was withdrawn. So this is quite interesting, but also raises a number of ethical questions. Other important reflections are, for example, Google has obtained a patent on robot personalities. So what will happen if the robot is programmed to take on the personality of real-world people, like a celebrity or a deceased person? Would this be a door to have humanoids living forever and in several places? Also, with service skills and personalities in place, robots could replace many customer services, and we're seeing this already. And they have the potential to take over many more human staff positions once robots are cheaper and more efficient. And finally, another controversial example is the citizenship that Saudi Arabia gave to the social humanoid robot, Sophia. And I guess by having citizenship, would she be able to vote or get married? So I think these are important questions for us to reflect on.
Dr. Pinto, we'll have a minute. You're in a minute. We'll have a minute, yes?
Yes. Virtual reality has increasingly entered our lives with headsets that can be used with our own phones. And in mental health, VR allows us to recreate the scenarios in which the psychological difficulties occur. So, for example, exposing the person to the environment of a packed tube that triggers the phobia, or Q exposure triggering the cave rings associated with their alcohol abuse and smoking. There's also been research with veterans with PTSD in the States that included virtual therapists, and it showed that veterans were more likely to reveal information to virtual coaches than face-to-face. Virtual coaches can respond predictively and efficaciously. They never fatigue, and they're not subject to transference and counter-transference reactions that can compromise communication. So I think these also raises important discussions for us in terms of the role of humans. AI is increasing. I'm not going to focus too much for the interest of time, but I'm just going to focus on some predictions that by 2036, AI would be filling our roles. There have been a number of examples that different devices have been used, and they raised issues in terms of, for example, this fitness tracking app Strava that gave away the location of secret USA Army bases through the geolocation data. So, of course, this raises a number of ethical questions. And finally, it has been said that AI will allow doctors to be more human. But I guess we can expect and extend and reflect whether technology is allowing humans to become more humane. So in the interest of time, I'll finish here. Thank you very much for your attention, and I hope we can discuss this further in the end.
Thank you, Doctor, very much for a great presentation. So I'm sorry that I'm kind of pressing with the issue. At the same time, you have to know for everybody goes, probably in your presentations, there are some parts that correlate with the others, try to be more flexible. And let's move to our next presenter, that he's going to talk to us about chatbots, consent and care, navigating AI ethics in psychiatry. The presenter is Dr. Sonam Saxena from the Institute of Human Behavior and Allied Sciences in New Delhi, who is a senior resident in psychiatry of IHSBAS in New Delhi, India, and founder of Neuronal Fix Clinic. With a strong academic and research foundation, he has presented at national and international platforms, including AQPMC and the WPA. Her clinical and research interests span digital psychiatry, neurodevelopmental disorders in adults, and caregiving, burden and severe mental illness. The floor is yours.
Very good afternoon to all the esteemed members, and I am here today to walk you through the ethical maze of using AI chatbots in psychiatry, where hope meets standard hazards and ethics meet the standard algorithms. So the AI chatbots in psychiatry can pose as a promise as well as a peril. Chatbots offer increased accessibility.
You're not presenting in full screen. It's not full screen.
Full screen would be better.
Is it visible now?
No, not full screen. Try the upstairs that says view, go up. No, at the same tab that you had with the presentation. In your put it again as it was. You see, open the presentation. Try with your mouse upstairs that says file edit view, up, file edit view, okay, PowerPoint, okay. File edit, yeah. Or double click there.
Yeah.
Yes.
Perfect.
Okay, yeah, I got it. So good afternoon to all. So I'll walk you through the ethical maze of AI chatbots, where hope meets hazard and ethics meet algorithms. So chatbots offer increased accessibility, cost effectiveness, and anonymity for those seeking help. It also provides therapeutic support. That is, it's delivering cognitive behavioral therapy, dialectical behavioral therapy, or mindfulness-based therapy interventions. It offers motivational interviewing techniques, and it uses behavioral activation strategies to reduce avoidance and promote activity. So it is also used in screening and assessment by conducting preliminary mental health screenings for disorders using standardized tools such as GAD-7 for anxiety and HAM-A, HAM-D for anxiety and depression respectively. And it also provides a crisis support by providing just-in-time coping tools, as was discussed before too, and by breathing, journaling, and relaxation exercises, etc. And some bots use emotional AI to adjust responses based on tone or language patterns. It is also providing multilingual support, and it is available 24/7, thus bridging the gaps in regions with mental health professional shortages. It is also useful in digital health platforms, and it can be integrated with wearables such as the watches, the Apple Watch or a Garmin watch for an example, to offer a biofeedback informed mental health suggestions. And it is used in a blended care model, which is something to do that the chatbots are working in complement to the in-person therapy session or a telepsychiatry session. And it can be personalized via the AI by learning the user preferences and adaptation to language, timing, and interventions accordingly. I think there is some issue in sharing. Is it showing now? Can you please confirm?
Yes.
Yes, okay.
So the informed consent is an ethical backbone of any care, ensuring people that they should be knowing what they are agreeing to. So it is foundational, it is a foundational ethical and legal principle, ensuring individuals understand and voluntarily agree to participate in a care or research, particularly critical when using AI tools or any chatbot. And why is it crucial in AI contexts? That it allows the patients to retain control over decisions involving AI. Secondly, the complexity of AI tools is that it requires informed consent to be simplified, transparent, and adapted for a better patient understanding. And individuals with psychiatric conditions, such as uh, the ones with the bipolar disorder, who are vulnerable, or a schizophrenic patient, who may also face challenges with comprehension. They require enhanced consent protocols to protect their autonomy. And AI may use data. Again, go on. AI may use data over time in different contexts or for secondary purposes, where consent must cover scope, reuse, and sharing. So when is informed consent mandatory? That is, it is important, it is imperative when AI interacts directly with the patients via the chatbots, or when sensitive health data is collected, stored, or analyzed, when data is to be shared or reused into evolving algorithms, in studies involving the audio, video, or longitudinal tracking, and when dealing with high risk or psychiatric populations, such as those having any suicidal tendencies. And essential elements of ethical AI consent needs clarity. That is, it should use an accessible, jargon-free language. It should be verifying the understanding, especially with the vulnerable individuals or the patients, and the voluntariness. It should ensure that no coercion or undue influence should be there, and it should be revocable, such as that the patient must be able to withdraw consent at any point of time without any penalty. So it should be a collaborative approach. That is, the technology developers, mental health specialists, ethicists, legislators, and patients must work together to develop AI in psychiatry in an ethical manner. Secondly, it should be continuously learning and adapting, so that it is also following the ethical standards, and the laws must be continuously learned and adapted as well. And it should focus on the patient's well-being. That is, it should have the patient should have the access to a high quality care, and it should be the main objective for an AI to achieve as a tool. So AI chatbots can offer a 24/7 support, reaching the underserved populations and reducing the financial barriers to care. The anonymity offered by chatbots can help individuals feel more comfortable seeking help, lessening the stigma associated with the mental health disorders. And it should be providing an early detection and prevention by identifying individuals at risk and developing mental health conditions, allowing for proactive interventions and potentially preventing crisis. And they should be giving some help in tailoring treatment plans based on individuals' needs, potentially leading to an effective or efficient interventions. So here by this chart, we can see that AI is helpful in early detection of a mental health disorder by analyzing electronic health records, as well as analyzing speech, text, or facial cues. And it is helpful in predictive models such as a multifactorial predictive model, and in improving the treatment outcomes. So when AI gets it wrong, a chatbot may suggest outdated or a risky drug information. That is, for an example, it may suggest benzodiazepine for anxiety in a patient without any context, and they may lack follow-up and personalization. That is, that they can give a misguided drug advice, such as giving again a benzodiazepine or a mood stabilizer to a person who might not need it, and it might cause further a serious patient harm. So who is responsible for this? when we can say that chatbots errors they lack clarity and they lack accountability as well. So they are inadequate in a high risk situation such as suicidality, and human clinicians bear a duty of care, that is mental health professionals must regularly supervise AI tools, and there should be clear laws which are needed to define who is responsible if something goes wrong.
We have 30 seconds.
Yes. So chatbots must not suggest, prescribe, or adjust drugs, and medication advice requires human judgment. That is, ethical AI should support role and it should not substitute. So never change a medication based on a chatbot advice, because AI is a tool, not a doctor. Thank you.
Thank you very much for the very great presentation about chatbots and all that has to do with them. And let's move on to our next presenter, Mr. Jibri Musa from Ahmad University, Somaliland. He's going to talk to us about digital psychiatry education in Somaliland, the promise of AI in medical education. Mr. Musa is an academic psychiatrist and a global health specialist. He's an assistant professor in psychiatry at Ahmad University in Borama, in Somaliland. And he's very interested in digital mental health education, which I believe is the core issue of all these actions that we try to make. Mr. Musa, the floor is yours. The cloud.
Thank you very much. I will just go into what digital psychiatry education holds for a low or middle country setting like Somaliland. I have nothing to declare here. Digital psychiatry education in Somaliland had a long story. To take you to the context, Somaliland is a territory in northern Somalia. Mental health education is integrated to psychiatry education since 2007 because this region has been going through a lot of conflicts. King's Cross London has been vital in bringing psychiatry to medical education there. Due to low number of psychiatrists, most of the teaching were delivered via digital teaching, particularly during the COVID times when nobody was traveling, and we developed modules in digital psychiatry to deliver all sorts of teaching in psychiatry. And then few psychiatry faculty members were able to deliver bedside teaching. And we have the only residency in family, the only residency we have is family medicine, and this one, we are lucky to introduce the psychiatry module using digital psychiatry by partnering with Department of Psychiatry at the University of Alberta in Canada, and we were able to deliver to start to deliver psychiatry teaching. And I will go to what we have been doing in the last year in integrating AI in our psychiatry education. First, we tried to pilot some of the teaching sessions design using ChatGPT in designing some teaching sessions in education psychiatry. This year, we chose child and adolescent health teaching using AI to generate the lecture. And the intention was to see if people in medical educators in low and middle income countries can utilize the tools of artificial intelligence in designing medical education modules. What we did is that when we fed with ChatGPT, design a teaching module on child adolescent health for students in Somaliland, what the ChatGPT was able to was come up with a very short 10 slides presentation, not only on the core principles of child and adolescent mental health disorders and the topics we teach, like autism spectrum disorder, ADHD, learning disability, things like that. But it went beyond that, and it combined epidemiology from Africa, 3 more modules, both pharmacological, non-pharmacological, and shared some of the latest studies. The interesting thing that ChatGPT showed us was that it did not bring a presentation with busy slides. It did not use very condensed slides. It just presented what we were able to teach our students. And sometimes when a medical educator is teaching, may use a textbook to generate the presentation. But this one, it went beyond the slide presentation and preparation by combining literature. in a way that the teachers might miss, like latest studies from Africa, for example, and comparing it with other low and middle income countries. And this is the presentation is generated. The way it generated, it tried to reduce the slides and present the key principles, and that's what I was saying, and that the ChatGPT can have a promise in helping medical educators in designing classes. What we have learned was that artificial intelligence combines topics. It goes to, as I said, issues in epidemiology, clinical teaching, but it also shows if there is any update from the context that you are teaching on child and adolescent mental health issues. For example, it may combine latest information from community-based projects, if there's like a community health interventions, like a community initiatives that the students might be needed to be informed. And then it helps sometimes to help the teacher if they are doing like bedside. In our class, what we used to do is flip chat classroom, where we send the students these presentations, they read it, and they suggest the readings, and they come back. And then we usually do is the small and large group sessions. If you are doing digital teaching in a breakout rooms, if you are doing physical classes, like small groups, and still ChatGPT was able to deliver that. And then we asked the students what they thought about using artificial intelligence in their teaching. The students shared that they preferred it because it helps the teachers and the students to co-create teaching. And if the students are involved, and students were interested, if they will be able to be involved. The students like to bring artificial intelligence tools to their classrooms, and the students wanted if artificial intelligence tools can help them in their bedside teaching. There are some pitfalls when it comes to artificial intelligence in teaching and in medical education. The first one is ethics, and I will give you an example. There was a pre-course survey that we wanted to give to family medicine residents on issues related to primary care mental health. I wanted to do pre-course and both-course survey. And what we found in the assessment of the students is that some of the students using ChatGPT in answering some of the essay and exam questions in the pre-course. And then as a medical teacher was reported is also to consider the quality of education and also issues related to ethics from the students and also from faculty members. I would like to end the presentation this because of the interest of time. Thank you very much, and let's move on.
Perfect. Thank you very much for a very nice presentation again. I'm very, very happy that I see that we going and touching all the aspects that artificial intelligence has opened in discussion. Let's move to our next presenter that's going to talk to us about the use of AI in clinical decision making and teaching in an outpatient practice. We're talking about Dr. Jose Hawayek from Broward to the Health Hospital, my psychiatrist clinic in the US. Dr. Jose Hawayek is a board-certified psychiatrist, born in Puerto Rico to a Lebanese father and a Spanish mother. He's fluent in English and Spanish. He provides compassionate care to patients, and hence his MD cum laude from the University of Puerto Rico and completed residency in Larkin Community Hospital, serving as co-chief resident. Doctor, the cloud is yours, not the floor.
Thank you so much. Everybody can see my screen okay?
Yes, perfect.
Perfect. Well, welcome everyone. I'll try and be brief in my presentation as we've already gone over a lot of the other points that I was going to touch on. I'm going to focus more on the teaching within the outpatient practice setting, which is at the residency level here in the United States, and a little bit about how that also happens with what we call mid-levels, nurse practitioners, PAs, physician assistants, etc. So no disclosures on my behalf. Get the little one there. No disclosures on my behalf for conflict. So AI and clinical decision making. Basically, AI tools are increasingly used to support our diagnostic formulation and treatment decision making. We can use it to create croquis. We can use it to help explain the patient's different conditions, how they split. It's very useful when utilizing the DSM-5 TR criteria to be able to delineate better and more precisely how to give out diagnoses, specifically when it comes to timelines, testing of different previous medications, etc. They're not replacements for clinical reasoning, but it can really provide a powerful augmentation and simplify the way that we are doing our diagnostic procedures. It can inform in treatment planning. It can help improve risk stratification, acknowledging whether certain treatments have been effective in the past when integrated with patients' medical records. It's particularly useful when trialing new patients to your practice or when navigating very complex, ambiguous cases. So enhancing patient engagement. AI can be used to deliver tailored psychoeducation. At my current practice, we use an AI model that automatically, once a patient is assigned a diagnosis and a treatment plan, it'll actually forward the medication interactions. It will forward over the diagnostic criteria, what to expect, disease progression, resolution of symptoms, things to watch out for. And this has been very useful because it not only helps us explain to the patient what's going on, it gives them a viable resource to be able to search further by themselves, and also involves family members. It really supports the behavioral activation adherence by having patients feel more involved in their treatment and understanding better what's going on, as well as giving them an accessible tool. It forwards that physician-patient relationship to the point where we've noticed that we have an uptick on the patient adherence to treatment and less hospitalization incidents, which is what we mainly watch out for here in our practices. That's all to say that it basically builds therapeutic continuity. I want to reinstate again that this is not a substitution for the physician-patient relationship. This just enhances it. As one of the previous colleagues said, it's a tool that helps us get further along in that relationship. So AI in teaching psychiatry residents. As Dr. Musa said before, one of the big issues has been cheating lately on exams. Once we're at the level of residency, cheating on exams is kind of hard. There's not that many exams in residency, thankfully. But the big thing is it provides, on the one hand, it can provide a guiding template for residents to follow to understand easier diagnostic criteria and going down the logistical steps. It can really give back real-time documentation feedback to tell our residents where their notes are lacking, how to make a better note. It's even gotten to the point where it helps with biotherapy feedback to be able to help residents and trainees understand how to enhance their techniques further. There's been a good proven use of AI techniques for EMDR, eye movement desensitization therapy, which has been very helpful in PTSD patients. It really helps residents in a way learn confidence and how to be consistent, especially if direct supervision is limited. It has really helped with that. The issue is it has also led to some, I would call it laziness, but it leads to some issues with residents depending then so much on AI where some of the basic skills can be missed. And that's why a very important thing to focus on is that human-to-human interaction and how to do a proper note. The argument I use in my practice and with my residents all the time is the argument of a calculator. You need to learn how to do your multiplication tables first, and you need to be able to learn how to add and subtract before you can start doing, quantitative physics. If you skip all those basic steps, you're not going to know when the AI model is failing or not. And the other big issue we're having is a large increment in the different AI models with different specifications. ChatGPT is the most popular, but now we have AI models that are popping up into every EMR, electronic medical recording system. So there's a definite split in the data and a big bias that we're noticing. So ethical human considerations. AI can unintentionally amplify inequalities or depersonalize care if applied carelessly. We must demand as practitioners and as teachers, transparency from vendors. We would like to see their testing bias regularly. We would like to protect the therapeutic relationship central to psychiatric care. We really want to be able to focus on that human connection. At the end of the day, we really want to be able to connect with our patients and foster a longevity relationship where they feel comfortable in sharing with us and not just think like, oh, I'm just going to go to the doctor and see him and he's just going to focus on, saying different questions so it can all be written down into a note and bill and make money. The whole goal here is to treat humans and to make ourselves better and help people be better. So practical implementation strategies. Effective implementation requires cautious piloting. You need open dialogue and robust training. AI right now, the way they want to tout it is as a plug and play deal, which basically means just to put it into whichever system you're using or into your practice and then just let it sort of take over and improve and optimize everything. But there needs to be thoughtful integration into the clinical and teaching cultures. Everybody here comes from a different place, a different training modality and method. And really, AI can't just be thrown in like adding cherries to a salad. You need to be able to integrate it individually to the cultures, understand the type of patients you're treating, understand the current use and guidelines of where you're at. Here in the United States, we have to provide disclosure when you're using AI for anything else other than just note-taking. But even at the point, we're at the point where AI has been integrated, plug-and-play style, to most EMR records to be able to document notes faster, given the focus that we have on efficiency and getting through the day faster. There needs to be a built-in feedback mechanism and an oversight mechanism to be able to retrain the AI and make sure it's adjusting to the real-time data and not past language model training. Oh, give me a second. Oof, I think it's, I might have skipped one, but basically just develop clear protocols. You really want to be able to start implementing AI slowly. Second.
30 seconds barrier.
No worries. I'll just, right here at the end. So AI will not replace psychiatry. Psychiatrists who understand AI will likely replace those who don't. We would like to be the leaders in its clinical integration, ensure that it complements rather than undermines values and expertise in psychiatry. The future of psychiatry will likely be hybrid, and I honestly see that as a great event for all of us to be able to help more patients and reach out further. And thank you.
Thank you very much for an excellent presentation. I see that the issue that replacing us comes a lot, but we're going to discuss it also in the end and see some insights in that. Let's move to the next presentation about leveraging digital tools for enhanced mental health surveillance. The presenter is Dr. Yesiru Adeyemi Karim from Neuropsychiatric Hospital in Aro in Abeokuta in Nigeria. Dr. Karim is a consultant psychiatrist at the Neuropsychiatric Hospital Aro, Abeokuta in Nigeria. He's an advanced resident at the field of epidemiology and laboratory training program FELTP, pillar of the Africa CDC Mental Health Leadership Program at the School of Public Health in the University of Ghana. He's a General Secretary of the Early Career Psychiatrists that we're making today this webinar, the section of the Association of Psychiatrists in Nigeria, and so on. Dr. Yesiru, the cloud is yours.
Presenting on leveraging digital tools for enhanced mental health surveillance. So I want to make a disclosure that I have no conflict to declare. So, as an introduction, mental illnesses are on the rise, especially among at-risk populations and the underserved. They become one of the most critical areas of focus in a global health, with conditions such as depression affecting millions nationwide. Thus, the need for an effective surveillance and timely intervention, which is paramount. Despite this, the use of surveillance for conditions is mostly devoid of mental illnesses, and where it is available, they are not accessible given the traditional methods being employed, which rely heavily on in-person interviews, surveys, and evaluation. Thus, in response to this challenge, digital tools have emerged as a revolutionary instrument in mental health surveillance, offering unprecedented opportunities to monitor, analyze, and respond to mental health needs. What is surveillance? Surveillance is described as an ongoing systematic method to collect data, analyze data, interpret data, communicate, and take public health action. And this cycle continues right from making diagnosis or detecting cases. It could be of different types. We have the passive surveillance and active surveillance and all that. But what is common is passive surveillance, in which the health workers, like mental health physicians, will make diagnoses of cases, and then the public health workers come to have access to it. But in terms of outbreak, we do an active surveillance where the public health physicians go all out in search for these cases. So this is the WHO schema of information flow for surveillance. Interestingly, what is being available mostly is for communicable diseases. And we know with the upsurge of mental illnesses, the non-communicable could also follow this format as well, starting from international level, where weekly reports are being released, then the central level, that's national level, where nationals release epidemiological bulletins, then the intermediate level, that's the region within each country, and then the district level. We'll expect that in taking data from our local level in the hospitals and our respective districts, these data are being forwarded up to the national and, of course, international level for public health action and epidemiological control. These are some of the tools that can be applied for mental health surveillance using online platforms where emotional tones and posts can be analyzed systematically, and then for crisis intervention, where abnormal behaviors can be flagged for immediate attention by mental health professionals. I'm sure these are going on in different countries. They also need to develop mobile applications which can trap mood and allow individuals to log in their feelings on a daily basis, which enables the users to recognize emotional patterns and triggers. And of course, therapeutic applications can connect users with their therapists and enable remote interventions. And then devices that have been described, different devices that can be able to detect sleep patterns, epilepsies, and even mood changes. And can even be used for anxiety, where they can detect changes in heart rates and even physical activity that may indicate an ongoing anxiety. And AI, chatbots, and others that have been earlier discussed by the previous speakers. So what are some of the benefits of leveraging these tools? One of it is that it can be used for analysis, can be used to identify trends and patterns, and of course inform mental health policies. And also can be used clinically for continuing mental health monitoring, for detection, personalized care, and management of conditions effectively. And it can also help to make services readily available and accessible by overcoming different barriers, thus reaching the underserved population in remote areas, and can be used for real-time monitoring, which can help to enably detect early potential issues. And it's also cost-effective because it removes all the financial burden associated with traditional surveillance, and it can be scaled to large collection analysis and offer insights at both individual and population levels. So what we're doing in Africa, particularly in Ghana. In this year, we have designed a tool to evaluate substance use in the Greater Accra region, Ghana. And here I am with the information officer trying to use the system to draw out the tools and the information. And here, just last month, we all heard of a COVID-19 resurgence in Ghana. Here, I and my team, we designed a tool, COVID-19 mental health impact tool in Ghana, where we used to access COVID-19 cases. Here I am with this person from Sierra Leone, this person is from Ghana. We're trying to compile the two together. And with this tool, we're able to access psychological distress among cases and controls of COVID-19 in Ghana, West African region. So, as I said, it's also been known that apart from digital tools, one other tool that is important is AI, which is also a form of digital tool. And these are different studies that have noted the role of AI in surveillance. One of it can be used to predict spread of illnesses and even contact of mental illnesses, and also used to transform this surveillance. And also AI can also help in promoting public institutions, and of course in global collaboration, which are all forms of digital surveillances. So of course there are some challenges. One is data privacy, because we know that we need confidentiality and securing sensitive mental health data. Of course, there could be the world is not equal, so there is one digital divide where some populations do not have equal access with technologies that may enable them as vulnerable. And of the ethical considerations, issues of transparency, anonymity, informed consent need to be thoroughly addressed while trying to utilize mental health care. The future directions, one, the future of digital tools mental surveillance is quite a promising one. So with emerging technologies, this can enhance mental health monitoring and interventions. So there also be need for collaboration moving forward between developers and mental professionals and policymakers, which will be essential to address existing challenges and maximizing potential of data tools. Integrating data tools into mental health public system will lead to more proactive, personalized, and equitable mental health care. I'll conclude that digital mental health services has transformed the surveillance in ways that mental health is monitored and being managed, and through applications and devices and also AI, these tools offer innovative solutions to long-standing challenges in mental health care. So while challenges may remain, the potential of digital tools they far outweigh the drawbacks, making them indispensable in the pursuit of better mental health outcomes worldwide. Thank you for listening. I want to acknowledge the African CDC that has given us the platform to innovate mental health digital tools into surveillance, and my faculty and my institution. Thank you all.
Thank you. Thank you, Doctor. And it's very crucial to see people all over the world, and especially from Africa, that is moving very fast in many sectors, seeing that you're trying to do things regarding AI. And without losing any time, I'm going to go to Lamia directly, and we're going to leave the questions for the end and move to our panel so that we can keep us the smallest time possible for our colleagues, because we know that we're all super busy and we have to get the most out of our time. Lamia.
Thank you, Nikos. I would like to thank all the presenters for their incredible presentations. And as Nikos said before, we apologize for overrunning with time with all these technical issues. We understand that some of you might leave, but we would appreciate if you stay and contribute also with your experiences, either by asking questions or also raising your hand and asking the questions lively. So now we are moving to the panel discussion, and we have the pleasure of welcoming 3 great panelists with diverse backgrounds, but the same extensive experience in using AI tools in their daily practice and care. And we start with Dr. George Dafoulas, which is an internist with an MBA in health management. He was a visiting scholar at CSAEL, MIT, Cambridge, Boston, and Matrix, Stanford Medical School, USA. He's working on different topics related to open source, open science for global health. Dr. George, the first question that we have for you, are there governance models, including policies and legislations regulating AI and mental health that span international borders? And if not, what do you recommend?
Yeah, thank you for inviting me. It's great to see that one more domain of clinical medicine is tackling these issues. I have attended in my association, the Internal Medicine Association in Europe, such an event. So great to see that you tackle this in mental health as well. I can talk about Europe. Europe is considered the most conservative in this approach. So they just passed the AI Act, as it's called, and it has special provisions for special use of high risk, as they call it, applications of AI, which include the medical field. So at least in the European legislation, this new regulation doesn't specify one disease, for example, mental health, separate from the others. It categorizes every aspect of medical use of AI in high risk. This means certain extra provisions of certification. There are going to be special authorities like the medical device regulation that regulates the medical device. There's going to be an extra layer of security for the AI Act algorithms. I know that FDA is doing something similar with a different concept, not so conservative like the European. I'm not aware of the other continents, and this is a challenge I see. There was lately 2 events, global events, supported, one by the French presidency and another one by the UN, about the coordination of the AI policies, and there was many disagreements. So it's going to be a challenge to regulate it across continents, but at least in some continents already there are some legal guidance and legislation in place.
Thank you very much, Dr. George. Actually, it's very interesting to know that Europe is still behind, while in other continents, such as Africa and low and middle income country, AI integration is widespread. And actually, even the WHO is starting now on working on guidelines on how to use AI in our clinical care. So I guess the field is still witnessing more and more changes in the future. So I will move now to our next panel speaker, Dr. Nikolaos Gouvas, which had the honor of chairing this session since the beginning. Dr. Nikolaos is a psychiatrist who combined extensive clinical experience with pioneering digital mental health and AI applications, currently serving as the head of AI for the digital mental health section and AI group of the World Psychiatric Association. He founded Melapus, Greece's first telepsychiatry platform, and chairs the innovative technology section. Dr. Gouvas, what are the steps that you think must be done so that mental health specialists can benefit and not stay behind in this significant area and field?
This is an excellent point. Before starting, I have to point out again, we have to understand one thing. AI is moving very, very, very fast. In COVID, something happened, and we kind of were coerced, all the mental health professionals, because the Melapus platform that I made was telepsychiatry. And before COVID, a large majority of them were thinking that that was something that's going to come in 10 years. This is the same thing with AI, and that comes with a bit of, a skepticism, because people, the only question that they make to themselves is that if they're going to be replaced. In reality, as I said, it's not the point that we're going to be replaced. That, in my view, there are some key steps, 3 key steps that we have to make. First of all, we need to have education and digital upskilling. We reach to a point now that all our patients already are coming to see us, and that they already talk with ChatGPT or Gemini and ask questions that they're going to ask us, and they're making debates based on that. It's not enough to just talk about AI. We have to integrate practical AI training in general into psychiatry, especially in young, but also in older colleagues, which are very difficult to do new things after the age of 50. Also, secondly, we have to have clear guidelines and standards. Already there's a huge work done with leader Don Hildy from our section, and of course, we need more help. Anybody can help from the sections, from both sections, to move forward this issue, because guidelines is a very serious issue. Many clinicians feel lost because they don't know what's safe, what's ethical, what's scientifically sound, and we have to do something about it. And third, we must co-create with the tools. So far the industry is working without, in reality, having the opinion of one doctor or 2 doctors. In reality, we have to make mental health professionals to join the developers and make sure that the AI tools reflect the real clinical needs. So to sum it up, we have to educate yourselves, set clear standards, and co-create the right tools, because AI is not coming, it's already here, and it's not here to replace us, but to amplify us. And the doctors who know, who do use AI, they're going to thrive. The ones who don't will fall behind. It's not good to have it in the future.
Thank you very much, Dr. Gouvas. So you're saying that today using AI is a must. We need to know how to use it and how to deal with it. We need to know about the ethical considerations. because we need this to communicate with our patients. We cannot communicate anymore with them if we are behind and we don't know about all these AI considerations.
It's demonized in a way. You know, the majority of the clinicians are demonizing it in a way that this is something that is not like me, you know. But the issue here is that you have for free someone to be there to help you, not to override you. And we have to get all the potential that it has.
Sure. Perfect. Thank you very much for your insight. And now we move to our last panelist, Dr. Alex Padini. Dr. Alex is a child and adolescent psychiatrist currently pursuing a master's degree at the Federal University of Rio Grande do Sul with a research focus on autism in adult women. He currently serves as the co-chair of the ECP section of the WPA and as president of the Rio Grande do Sul chapter of the Brazilian Association of Neurology Psychiatry for Childhood and Adolescence. Alex, what ethical dilemma have you encountered when integrating AI into outpatient psychiatric care, and what did you learn from these experiences as an ECP working and integrating AI in your daily practice?
Hello, everyone. Thank you very much, Lamia, for your kind introduction. This is a really interesting question. I would like to share some personal experiences on that, and I'm happy to later discuss and also give advices to anyone who wants to start using AI. In my outpatient practice, I mainly use AI to transcribe clinical notes right after sessions and to generate initial drafts of medical reports and evaluations, which I always review carefully before finalizing. These tools save time, but they also raise ethical concerns like whether it's safe to send sensitive information to external servers or how much nuance might be lost when AI summarizes complex personal histories. To address this, I include a specific clause in my general informed consent form, which all patients and families complete before the first appointment, explicitly stating that AI may be used to assist with transcription. At the same time, I've noticed many parents come to appointments with information they've obtained through open access AI platforms, which are not always reliable or clinically appropriate. These experiences have taught me the importance of transparency, critical review of AI-generated content, and helping families understand both the possibilities and the limits of these technologies, always reinforcing that AI supports but never replaces human clinical judgment. Thank you.
Thanks, Alex. So just backing up on what you are saying, I was wondering, as you know, like a user of AI, what maybe AI would you suggest which would raise maybe less privacy issues, or is there any evidence for one that is prevailing over others to trust?
Yes, there are some platforms that explicitly states that the information is going to be used to add up to the large language models. Others don't. Most of the common platforms like ChatGPT, Gemini, they state that there are some that can be used even with specific external devices as Plod AI, and there are some other specific to countries that can be used to record medical appointments. But I think that is like a long list. We can discuss it. Anyone can contact me. We can go with that. Thank you.
Okay, perfect. Thank you to all the panelists for sharing their experiences and knowledge about this critical topic. Now I would like to open the floor for questions, either for presenters or for panelists. So please either raise your hand or write your question in the chat, and Dr. Joanne would make sure to report it to us.
Thank you very much, Lamia. I just wanted to say that many of you, Hannah, Jibril, were discussing in the chat about how can we better students. This is one big concern that many of you have discussed in the chat. So any of the participants want to
Johan, 1 minute. There is an echo. Somebody has his microphone open. There is a continuous echo. We don't listen to what you are saying. Please check your microphones, please. Please repeat.
There is an echo.
Yeah, it's because the fire is.
Go, Johan.
Okay, now, right? Yeah, we're not, to inform all of you, we were transcribing all the things that were being said using an AI tool. That's why I had two mics open. So what I was saying is that in the chat discussion, many of you, Botirbek, Hannah, Jibril, Dr. Jose, were saying about the potentials of the AI, and one big concern is about how do we use AI in educating patients. I think it was Dr. Botirbek that he said we don't have to avoid AI, we have to include AI in our daily lives, but how can we improve this relation with AI, and how can we teach students to use AI in a better way?
Who's to answer?
Any of the participants.
Okay.
This is open now. Botirbek, maybe we can give the word to the ones who were listeners. Botirbek, Hannah, if you are still here, you were discussing this, please go ahead. And then also the panelists, Dr. George, Dr. Nikos, and Dr. Alex. They are not answering. Please, Dr. Nikos, go ahead.
So I believe that the core issue here is to integrate AI in a more engaging way. If we see what's happening around, in reality, AI is not something that we have. For example, if you're a teacher, put your students to use it, not put it in a way that it's only there to copy the, what they have to do for the weekend and get it back easily. Maybe if you know how to use ChatGPT, it can make small bots, if you want, that you can put it in a position to start doing specific tasks. For example, to follow up in a specific way that the medication is provided, for example, or to follow up in regarding of what data is coming up online. Of course, it's not 100%, accurate. And of course, we have to always think that in the past with Google, we had 103 million results in every enter that we pressed, and now we have just one. But at the same time, I believe by using it and putting it in a position to interact with it, talk with it, and know how to give the prompts, because the whole issue with the artificial intelligence is to know how to give the prompts, how to give the instructions to the AI to help you. I think that by using it more and putting students more to use it, not as an extra tool to do sideways things, I believe that's going to be more helpful, and it's going to be every day in our lives. Probably in my daily life as a doctor, I use it everywhere in everyday life. Something like this. I don't know. George, you have something extra to say?
The problem I am facing is, I shared this link now. If you are a medical doctor and you want to use officially, for example, Gen AI in Europe, there is only one Gen AI tool validated in the European market with the new MDR, this prohibited. Nothing else from everything you will see around you, the ChatGPT, whatever. Everything is illegal to use in medical practice in Europe unless you use this one. And that's it. It's a monopoly at the moment. It was published it was certified just 2 months ago. So practically, there is a lot of buzz of AI in the medical sector, but officially as a tool, there is not many that can be used. In the FDA, in the US market, there are more, but in the European market, for example, in Gen AI is only one. So practically, there are not so many opportunities to use Gen AI officially in medical practice at the moment.
Dr. Dafoulas, there is a question in the chat saying, what are the regulations in digital psychiatry AI? And what would you recommend these psychiatrists or all the psychiatrists for AI in the practice? What would you recommend to do? Because regulations are different according to countries, but what would you recommend to do?
Yes, there is many, apart from the legal ones, which is per country differ, the ethical aspects are very important because, for example, there are the present legislations and statements don't cover the AI dangers. For example, if you upload something, the info of a patient for research purposes in a Gen AI model that doesn't respect the GDPR, for example, in Europe, this means that this data goes, for example, to a server outside Europe. This is, even for research purposes, this is illegal in Europe. You also have to respect the ethical considerations you explained. When you deal with mental patients, they do not always have the capacity to agree, to consent. So these are even more dangerous in medical research with AI. So there is a lot of red tape, sometimes mines, not just red tapes, because they're not clear. So you should be very careful with the ethical boards and the legal aspects and the insurance agencies. Some insurance agencies for clinical trials don't insurance trials with AI. It's careful to see the small letters in the contract.
Okay, thank you very much. There is another question about research, but before going to this question, I wanted to say that Dr. Hannah is saying apologies that she cannot talk when I was asking her, but she agrees that we have to be involved in the misinformation or bias that AI can give us. Going to the question of research, which recommendations would you give to someone who wants to do research in AI? And I would like to maybe give this question to Dr. Mariana Pinto da Costa or Dr. Nikos, that you have been involved in creating an AI tool. This is also research and innovation. Or Dr. Pinto da Costa, please.
For research, it depends on how you're going to use it. If you put it, as Dr. George says, first line, it's kind of difficult at this point. But at the same time, you have to at least choose the things that you're going to use it, at least for the easy parts. It's very crucial to understand that maybe the legislation is open. Even telepsychiatry today, if after COVID, legislation is somewhere in the air. It's not quite clear, but it's out there working. So we have to understand how it works. So because if we understand how it works, we are more easy to know that we're going to be okay and nothing happens. The problem is when we use it without knowing what happens.
Okay, Dr. Mariana Pinto da Costa, I know you.
Yeah, and absolutely. I'm happy to add on that. So I'm based at King's College London, and we used AI in different research projects. And I've just pasted in the chat an example of how we use AI. So essentially, we have our electronic health record system in a pseudo-anonymized way. And this represents all patients that are seen in the 4 boroughs in South London, but equally also have a number of national units. And so we have developed more than 100 natural language processing algorithms that these ascertain data that are in electronic health records that is in free text. So, like in electronic health records that I was explaining initially, you have the structured data, which is normally a box, and you select, the different options. But then in psychiatry, as you all know, we are very good in writing a lot in free text. So what we do and what we didn't, and this is a very large infrastructure with lots of people that are employed to do that, is we develop natural language processing algorithms for a number of concepts, and then we are able to use it for research purposes. For example, I've personally have done a number of research looking at loneliness, and loneliness, it's not a concept that you write, in a box that the person is lonely or not, but clinicians, they write in their consultations a lot about the status and how patients are in terms of how they feel lonely. And so with these NLP algorithms that we have one for loneliness, but we have really like more than 100. So if you can check, you can see. we can then look at associations between different concepts that are in free text with other data. And this was approved in terms of, all the ethics approval and research governance. So I think it shows that when there's support and political will and the right infrastructure, we can use AI in different ways. And this is just like an example of, what we have been doing in the past years.
Okay, thank you very much, Mariana. Your insights from the UK are always very interesting and valuable for all of us. And I think, Dr. Alex, can I ask you if you can give some words about what is your expertise in this field?
Yes, are you seeing my screen? I just want to share this platform. It's called Open Evidence for people who like to look in other like ChatGPT and others that are not so confident the information. This Open Evidence platform has agreements with New England Journal, Mayo Clinic, JAMA Network, so it's searched directly on papers for anything that you'd like. So it's like a specialized for doctors ChatGPT. So you can like ask any questions, how to treat bipolar. So it will search every evidence that there is and will give you like anything that you want with a fairly good answer. So, and with references. So if you like to look for medical information there on the internet, this is probably the most safe platform. It's called Open Evidence. So just to share a little experience.
Thank you very much, Dr. Alex. Now to close, Dr. Lamia just shared the link in the chat. What I'm going to ask you now is to the 52 people here, please, I have just shared the link. If you can click the link, it's a 20-second questionnaire that we would like to ask you if you can complete it, so we have information about what is your view about this webinar. So I will be in silence for 20 seconds, 30 seconds. So please, if you can complete this form, the link is in the chat, so we will have your insights. You can criticize or do it as you want. It's valuable for all of us.
So Joanne, may I make a comment?
Yeah.
Okay. Hello, I think my name is Dr. Kalpan from India, and I dropped some comments in the chat box, and Dr. Jibril has written, unmute and share some insights. So I am basically on the WPA Leadership Council from the Conflict Management Resolution section. Can you hear me?
A little bit, not very clear. You were saying something about the conflict management.
Yes. So we had done a webinar series on technology, psychiatry, and mental health, and I am on the.
Okay, Dr. Darpan, I'm sorry, but we cannot hear very clearly what you're saying, and we're running out of time. I'm really sorry. You were interacting in the chat a lot.
Joanne, one question only to our esteemed president.
Thank you so much. Thank you.
Yeah.
I want please.
Before, I'm not going to finish yet, Dr. Nikos.
We are waiting for you still. No worries.
I just wanted to people fulfill the questionnaire of this survey. And now, Dr. Darpan, we have to close this webinar. I'm sorry. I think and I hope we'll have chances to meet in the future. So to conclude, I would give the word again
Thank you so much.
Okay, thank you. To conclude, I would give the word to the chairs of both sections, Dr. Lamia and Dr. Mucic. And meanwhile, I will also put the links of our both sections in the chat. So I'm finishing here. I give the word both to Dr. Mucic and Dr. Lamia.
And I put a question in the middle for Davor. Davor is the guy that with digital health in general is the oldest guy that we're around. I want his whole after all this webinar, all this journey, how do you feel about AI? How do you see things going forward? And of course, close the ceremony.
It was so interesting to hear different aspects of the story and some questions which I heard 20 years ago, not exactly about AI, but about telepsychiatry at that time, that ancient fear of being replaced, which is interesting, being replaced in Scandinavia, where waiting time for seeing psychiatrists is up to 3 years, which means that there are so many patients. And still we are afraid of being replaced. It is something for deeper analysis. Within the last few months, I've been promoting this book. This is my latest book, Digital Mental Health, traveling around the world and talking with my colleagues and finding out that we have no curriculum whatsoever except in India on medical faculties. We have no education whatsoever to psychiatry residents regarding digital tools. And it is what is frightening me more than whether AI will replace us. So I think really that we are always ending by pointing out how important it is to have driver's license before we sit in the car. And that driver's license we don't have, and we are ruining our reputation by not having it. And that's what I would love to say at the end. It is not optimism, but that's the reality. Thank you so much for your participation.
Yeah, so maybe just to summarize a little bit what I got from this webinar, from this amazing webinar, and again, thank all the participants and all the presenters and the panelists. Well, we all talked about that the integration of AI into diagnostic, therapeutic, and clinical reasoning stands at critical crossroads. There is a potential to enhance the efficiency, expand the insight, but we must remain vigilant in preserving the core of human cognitions. I think what's important is to realize that the challenge ahead isn't about resisting technology, but it's about ensuring it becomes our companion, not a crutch. You know, someone at some point talked about resistance, but I think having 60 people in this webinar is kind of a testimony about how people are interested in AI, and I'm impressed to know how people are using it, to which extent they are using it. So maybe it starts by a bottom-top approach. Maybe it's also about all these young people that will, you know, kind of encourage their seniors to integrate more and more AI in their clinical practice. So it's important at some point to move forward, to make guidelines and systems in place in order to regulate all this. And again, I would like to thank everyone and invite you to join the sections in order to connect, learn, and also maybe contribute to future opportunities like this one. Thanks, Joe, and over to you.
Great.
You are muted,
I think you're
Joan.
muted, Joan. I can't hear you.
Thanks. Sorry, I was saying thanks to all of you that have participated in this webinar, especially also to Dr. George Dafoles, who has been connecting to our webinar. And I hope we can collaborate again in the future, both sections. It was a great experience. And we, on behalf of both sections, I would like to say to the 50 people here, if you are not in any of these sections, get involved in any of the two sections. Thank you to all of you and have a nice afternoon, morning, or evening.
Bye-bye.
Have a great one. Thank you
Bye.
very much. Bye-bye.
Thank you so much. Great.
Thank you, Joe.
Lamia, well done. Well done.